Videos from families destroyed by OxyContin addiction set the tone.
And now our family approaches another holiday season without my son.
The current CEO and members of the wealthy family that founded Purdue Pharma, David and Kathy Sackler, all offering apologies.
I'm profoundly sorry.
I am deeply and profoundly sorry that OxyContin has played a role in any addiction and death.
I'm not sure that I'm aware of any family in America that's more evil than yours.
History is always messy. It's never easy to predict how certain forces will play out over the long term. At its core, the opiate and opioid epidemic emerged from some of the same forces that made the medical marijuana movement successful, particularly the notion that we must have compassion for the sick and dying. Though in this case, the primary concern were people who were suffering from chronic pain. Traditionally in the United States, physicians had been extremely wary of prescribing opiates. Their fear of addiction outweighed the suffering of patients in the grips of long-term debilitating pain. There were already voices in the 1950s who were highlighting the Sophie's choice that doctors were forced to make. As one physician put it, we must appreciate that severe, constant pain will destroy the morale of the sturdiest individual. But we are often loath to give liberal amounts of narcotics because the drug addiction itself may become a hideous spectacle. Physician training at that time also erred on the side of more pain, less addiction. But critics argued that in many, if not most cases, this was driven less by the facts of the matter than by an irrational fear of certain demon drugs. Kathleen Foley was a pain management specialist at Memorial Sloan Kettering Cancer Center in New York City. Her work demonstrated how extremely effective morphine was at reducing the suffering of patients with severe cancer-related pain. She researched these outcomes in the small groups of patients she worked with, and in 1981 and 1986 she published articles suggesting that addiction was rare in these cases of severe pain. With her colleague Russell Portnoy, Foley argued strenuously that physicians should pursue the long-term use of opiates in such cases. And they weren't the only ones. The World Health Organization also called for a more humane approach to pain. All of this constituted an emerging movement to consider pain management as a universal human right. Though perhaps even more influential was what should have been a relatively insignificant letter to a medical journal in 1980. The physician Herschel Jick of Boston University had been searching for data on just how many legitimate pain patients ended up addicted when treated with narcotics. He and his graduate assistant, Jane Porter, looked at over 12,000 records of people who had been treated with narcotics while in the hospital, and they were amazed to find that, of these, only 4 had become addicted. Their letter to the prestigious New England Journal of Medicine simply noted that these findings were, quote, interesting. Despite widespread use of narcotic drugs in hospitals, they wrote, the development of addiction is rare in medical patients with no history of addiction. Now, this was not a controlled study, nor was it a peer-reviewed article. It was simply a letter to the journal noting some interesting data. But much like the shaky evidence about crack babies that was swept up and immediately accepted in the growing momentum to punish drug users during the late 1980s, Porter and Jick, as the letter came to be known, began to be cited in academic publications as if it were a rigorous peer-reviewed study. Over the coming years, Porter and Jick would be cited more than 600 times by other scholars, with the vast majority of these citations failing to mention that this was not a controlled peer-reviewed study, or that the 12,000 patients reviewed were hospital inpatients being carefully monitored by physicians, not individuals who were being sent home with narcotics. In short, here was another case of dubious facts driving major developments in history. And at the very same time that compassion for cancer patients was giving momentum to the medical marijuana movement, it was also opening the door to the widespread prescribing of opiates and now opioid painkillers in the United States. And in both cases, there were greedy entrepreneurs poised to capitalize on the opportunity. Purdue Pharma was the most important of these. Founded by the 3 Sackler brothers in the 1950s, Purdue had pioneered modern, aggressive advertising techniques. And these were put to extremely effective use once the company began selling the slow-release opioid OxyContin in 1996. Because the drug had a time-release formula, and thus users would receive a gradual dose of the drug over the course of many hours, Purdue argued that it was non-addictive, though the label of the drug implicitly explained to addicts how to crush up the pills to get around that slow time release. Their aggressive marketing tactics were fixed on physicians who were already facing considerable pressure to be more liberal in their prescribing. Meanwhile, the FDA also buckled to the growing pressures and approved the prescribing of OxyContin in very high doses, convinced that the slow-release formula would indeed make the drug relatively non-addictive. But Purdue did not merely argue that OxyContin was appropriate for people dealing with severe pain from cancer or other ailments. They pushed the notion that it was also safe to use for moderate pain like toothaches and back problems. This wildly expanded the size of the market to the tune of $30 billion in profits for Purdue.
Once you've found the right doctor and have told him or her about your pain, don't be afraid to take what they give you. Often, it will be an opioid medication. Some patients may be afraid of taking opioids because they're perceived as too strong or addictive. But that is far from actual fact. Less than 1% of patients taking opioids actually become addicted. And any drowsiness that might occur when you start to take the medication will soon wear off in most patients.
By the early 2000s, a new wave of overdose deaths was becoming apparent in various parts of the country, though especially in the economically depressed portions of the Midwest, Northwest, and New England. The Ohio River Valley was essentially ground zero, as depressed communities saw a huge surge in the use of these drugs fueled both by physical and emotional pain. So-called pill mills began to spring up as unscrupulous physicians took advantage of the situation to enrich themselves.
As Anjanette Levy reports, doctors are accused of prescribing painkillers for cash and sex.
The opioid crisis here in Ohio and throughout this region is the public health and safety crisis of our lifetimes.
The bust by the Appalachian Regional Prescription Opioid Strike Force took place in Ohio, Kentucky, West Virginia, Tennessee, and Alabama. Others were busted in Pennsylvania and Louisiana. In Tennessee, the feds say one doctor called himself the Rock Doc, trading pills for sexual favors. Another doctor taken into custody, Morris Brown, in Dayton, Ohio.
That doctor allegedly operated a pill mill and funneled prescriptions to the pharmacy housed in his waiting room, which dispensed over 1.75 million pills in a 2-year period.
This clinic in Pikeville, Kentucky, was just one that was raided today. Many of the facilities were in rural parts of Appalachia, where healthcare services are scarce.
By the mid-2000s, Ohio opioid and opiate overdose deaths were dwarfing the numbers of people who died at the height of either the crack or AIDS epidemics. In Ohio in 2007, the number of deaths from overdose surpassed those from car crashes for the first time. Nationally, about 38,000 people die in car crashes each year. By 2008, opioid overdose deaths had surpassed that number as well. Though around that time, the epidemic was also beginning to take on a different hue. Up to that point, the main driver had been opioid prescription pills, but as the crisis came into focus and new restrictions on prescribing these drugs took shape, a rich market opportunity opened up for heroin, which Mexican traffickers in particular began to market extremely aggressively. By the early 2010s, heroin was becoming the drug of choice for a growing number of narcotic addicts. And then, as the scrutiny of the heroin trade increased, traffickers began adding the powerful, extremely deadly opioid fentanyl to their product, increasing the bang for the buck, but also the potential for overdose. This began a third wave of the epidemic. In May of 2020, the Centers for Disease Control reported more than 81,000 overdose deaths over the previous year, about 50,000 of those from opioids or opiates. Much like the response to crack in the late 1980s, the birth of the opioid epidemic reflected an almost perfect storm of circumstances. There was legitimate concern about the suffering of those with chronic, often terminal illnesses. There was the Porter and Jick letter that took on a life of its own. There was aggressive marketing by Purdue and other pharmaceutical firms. There were the overworked doctors under enormous pressure to keep their patients happy. And, like the neighborhoods that were devastated by crack in the 1980s, there were deeply depressed corners of American life that were highly vulnerable to drug addiction. But there was a major difference as well. The crack epidemic, which was associated overwhelmingly with black Americans, inspired an overwhelmingly punitive response from authorities, destroying millions of lives through long jail sentences and the scarlet letter of felony conviction. The opioid epidemic was, at least at first, overwhelmingly described as a white phenomenon, and the response has been overwhelmingly public health oriented rather than punitive. Critics are surely right that the difference in part stems from race, though they are probably also underestimating how effective the drug policy reform movement has been in changing the narrative about drugs since the 1980s. We've already seen how the collateral damage of the 1980s helped to propel the marijuana reform movement forward, and that same reformist spirit and activism surely has played a role here. Furthermore, at precisely the same time that OxyContin was first hitting the streets, the so-called brain disease model of addiction was becoming completely dominant in the United States. In 1997, Alan Leshner, the head of the National Institutes on Drug Abuse, or NIDA, argued famously that addiction was the product of the brain being hijacked by drugs, and that users became virtually powerless in the face of the brain changes driven by these substances. Users, in short, were sick. They suffered from a brain disease. The model was buoyed by advances in neuroscience that allowed the impressive mapping of brain activity, and since that time the brain disease model has completely dominated the federal government's framing of the drug problem, especially once Nora Volkow, one of this model's strongest advocates, became the director of NIDA in 2003, a post that she continues to hold. One of the great benefits of the disease model is that it has helped to destigmatize drug abuse, couching drug addicts as victims of an illness rather than deviants who should be punished. And that has surely had a significant effect on the response to the opioid epidemic over the last 20 years. Though conversely, we should also consider the possibility that the perceived whiteness of the opioid epidemic, and thus the sympathy of the media for these users, may also have served to popularize the disease model of addiction, just as the atmosphere of the 1980s led researchers to uncritically accept Porter and Jick. Indeed, there are significant problems with this model that many critics have been highlighting for years, namely that the vast majority of people who take addictive drugs don't become addicted, and that many long-term users simply stop when the circumstances are right. Probably the most famous example of this were the many heroin-addicted Vietnam veterans who simply upon returning to American soil and getting out of the horrible circumstances where they became addicted, were able to stop using at rates that were exponentially higher than what was considered normal. Most diseases don't simply disappear when you change your address. Clearly circumstances, like being trapped in a war zone, or a crumbling neighborhood, or a depressed post-industrial Midwestern town, really matter, as do other factors, like exposure to childhood or other trauma, genetics, and so forth. NIDA and Volkow are well aware of this complexity, but in public discourse we again see the tendency to wildly simplify. It has once again become all about demon drugs, OxyContin, or heroin, or fentanyl. And it's this tendency to simplify that constantly gets us into trouble, leading us to miss not only the real causes of our maladies, but the development of others right under our noses.